We characterize MS into different subtypes, phenotypes, if you will. The commonest is relapsing remitting. And this is where you have an attack of something affecting the central nervous system, comes on acutely or subacutely, lasts for days to weeks, and stops. Now, it may resolve anywhere from 0 to 100%, meaning that you may be fully recovered, or you may be left with some residual deficit, a limp, numbness, tingling, change in vision. But it stays stable over time until the next attack, and that's what makes it relapsing remitting. The period between those attacks, the time between those attacks, is extremely variable. It could be weeks, months, years, decades. And this is why prognostication in MS is so difficult, because of the serious neurologic diseases. This is the most variable, from extremely mild to very severe. Relapsing remitting can follow that entire course. Sometimes, in some people, the relapsing remitting phase will then enter a progressive phase, where in between attacks, there'll be gradual worsening. And it's not inexorable worsening, so it can fluctuate, but they gradually worsen. And they may or may not have superimposed attacks, but that gradual worsening between attacks is progressive disease. If they start out with a relapse, then it's secondary progressive disease. Some individuals, maybe 10 to 15% of MS, have what's called primary progressive MS. In primary progressive MS, they don't have an acute attack to start with. Instead, they start with the gradual worsening. Usually involves the legs, spastic paraparesis, and progresses on from there, again, at a variable rate. The two progressive phases both carry a worsening prognosis, in that most of the disability that we see, the lasting disability, is in patients with progressive disease. Now, when someone who starts out as primary progressive has an attack after they've already started the progression, we used to call that progressive relapsing MS. But more recently, we reviewed these phenotypes, and we decided to subtype them further as to whether there's activity or no activity, and whether, if you are in a progressive phase, whether you're progressing or whether you're stable. So what that does is, if you take a relapsing remitting patient and they come in to see you, you assess them for activity. Activity would be either an acute attack or a change in the MRI, a new T2 lesion or a new gadolinium enhancing lesion. And if that occurred over some fixed time period, and you could pick whatever period you want, we recommended 1 year. So someone comes in, I'll make an assessment 1 year down the road as to whether they had any activity or not, so they become relapsing remitting, active if they had had an attack, or active if they had had a change in their MRI. That holds for progressive patients too. So if you were a primary progressive patient and then you had an acute attack, which can happen, what used to be the old progressive relapsing, you now would be primary progressive active. Now, if you're primary progressive or secondary progressive already, then you may be characterized as either active or not active over, say, a 1 year period, but also whether you progressed or didn't progress. That is, did you get worse? And some progressive patients stay stable for long periods of time. And so for progressive individuals, they can be active and progressing, active but not progressing, progressing but not active, or neither active nor progressing and therefore stable. And so that's the modern characterization of the disease types. And we think it's more helpful now because we need to know what people are doing within a time frame to get a better idea on prognostication, which is not one of our strengths, but also to develop means of better gauging how people respond to our therapies.
When they revised the MS phenotypes in 2013 and it was published in 2014, they did away with one of the MS phenotypes, the so-called progressive relapsing. Previously, In the unusual MS patient that showed gradual worsening, slow progression from onset, they considered them either primary progressive or progressive relapsing. The only way they differentiated them was that the progressive relapsing patient subsequently had a superimposed acute attack or acute relapse. So if that happened, they were no longer considered primary progressive, and they were switched from primary progressive to progressive relapsing. After a number of years, it's become apparent that that was an artificial division. If you're progressive from onset, you're falling into a unique group. And we know that about 1.5% of primary progressive patients will have a clinical attack each year. It's not 100% separated that they can't have a clinical relapse. So they really combined primary progressive and progressive relapsing and did away with progressive relapsing. And so primary progressive is the unusual 10 to 15% of MS that shows gradual slow worsening from onset, shows about a decade later age of onset, often in the mid-40s, and shows an equal sex ratio, men as likely affected as women, the only MS phenotype that does not show a female predominance.